Hello, I'm Dr. Jeffrey Weber. I'm a medical oncologist at the Laura and Isaac Perlmutter Cancer Center here at NYU Langone Health in New York City. Today I'll be reporting to you on a couple of abstracts that relate to adjuvant and neoadjuvant therapy in melanoma. And also I'm going to cite very briefly a recent publication that also talks about neoadjuvant therapy, which really is a coming thing in the treatment of melanoma and many other cancers like lung cancer, head and neck, renal, etc. The first abstract was presented by Sapna Patel, and it was a follow-up on some very nice work from the SWOG 1801 trial, which was a clinical trial in which patients in a phase 2 style were randomly allocated to receive either neoadjuvant pembrolizumab times 3 cycles, then surgery, then adjuvant pembrolizumab, or just to go straight to surgery and then have adjuvant pembrolizumab. Adjuvant pembro, of course, is standard of care, FDA-approved therapy in resected stage 3 melanoma, and all of the patients in that original trial, SWOG 1801, had clinically detected disease either radiologically or palpably. And there, at 2 years, the event-free survival was 72% versus 49%, which is a very impressive difference with a p-value of 0.004 and a hazard ratio of 0.58. The presentation made at this ESMO meeting showed that the concordance in the pathologic assessment was pretty close to 90%, because in the real world, of course, you're going to have individual institutions doing pathologic assessment of neoadjuvant specimens, which I think has become evident over the last couple of years, clearly is prognostic for outcome. And the recurrence-free survival by pathologic response was also assessed in this trial, and you had a very nice 87 to 89% 2-year recurrence-free survival if you had a path CR, a 90% path CR, or more than a 50% path CR. But if it was a path non-response, meaning less than 50%, those patients did not do as well, and their recurrence-free survival was about 70% at 2 years. And again, if you look at major path response, meaning 90% necrosis or more, up to 100%, versus not having a major path response, clear difference, 88% at 2 years versus 80% in terms of event-free survival. And interestingly, if you look at the actual RECIST response, when you look at CAT scans pre and then at the time of surgery, it's actually about 50%, whereas the actual pathologic response rates are somewhat higher. And if you look at the response, or rather the recurrence-free survival by RECIST response, clear association. The patients who have a CR do the best. The patients who have progressive disease or no change are the ones who do the worst at 24 months. So what do we know? A significant portion of the specimens from this large randomized phase 2 cooperative group trial, I think it was 73% of the specimens were looked at, and the concordance was very good with central pathology and individual institutions. And the major pathologic response rate was 53%, which I think is quite respectable. And there's no question that at 2 years, both event-free and recurrence-free survival segregated by RECIST response and by pathologic response. Then again, as opposed to some other trials, there was a finite recurrence and event-free or event rate that occurred by 2 years, even if you had a major pathologic response. I think it was something like 88% event-free survival at 2 years, even with a major path response. And if you didn't have a major path response, of course, it was a significantly higher one, with about 70% if you had 50% necrosis or less. So again, more grist for the mill of neoadjuvant therapy in melanoma, which to some degree has become almost a standard of care in the community. I then reported on an update on the Keynote 942 trial, which was the first randomized trial of a neoantigen mRNA vaccine with pembrolizumab versus pembrolizumab alone. And again, many of the data have been presented. We do know that the immune-related adverse event rate of grade 3-4 is actually no different in the pembrolizumab control arm than in the pembrolizumab vaccine arm. In fact, it was 10% for the combo arm, 14% for pembrolizumab alone, which is quite favorable, although the overall toxicity, as we know, is of course higher. And again, just to refresh your memory, the recurrence-free survival rates were clearly superior for combo, with a hazard ratio of 0.56 and a p-value of 0.052, two-sided. The distant metastasis-free survival rate superior for the combo, again, with this time a hazard ratio of 0.34, highly favorable, 66% reduction in distant metastasis. And as we all know, there's been a recent press release that was a couple of months ago suggesting that at 3 years of follow-up, as opposed to the 2 years of follow-up that I presented both at AACR and ESMO, that the recurrence-free survival superiority for the combo now has a p-value of 0.019, much better p-value, and the distant metastasis-free survival benefit is maintained now at 3 years of follow-up. And what we now showed at ESMO is that if you were ctDNA positive or ctDNA negative, it still was better to get the combination versus single agent, both for distant metastasis-free and recurrence-free survival. And with ctDNA, you had 3 patterns. You were either negative all the way through, which is about 12 to 15% of the patients. Those patients did very well in terms of RFS. You could be a non-responder, meaning you either were negative and then became positive, or were positive all the way through, and those patients did very poorly. Or you could be a molecular ctDNA responder, where you were positive at baseline and then became negative, or were negative, then positive, then negative again. And those patients had an intermediate recurrence-free survival and distant metastasis-free survival, which has been shown in other cancers. And finally, we showed that if you were BRAF mutated or BRAF wild type, you still benefited from combination versus single agent for recurrence-free survival. And interestingly, the mutated patients seemed to have a better separation with a better hazard ratio. But whether you were mutated or wild type, you still did better with combo than with single agent pembrolizumab therapy in this randomized phase 2 study. And finally, there's the Neoadjuvant study, which was a very small single-arm neoadjuvant study just published in Nature Communications. And I simply mention it for 1 minute because even though it was a very small pilot study with 20 BRAF mutated patients who had vemurafenib, cobimetinib, and PD-L1 antibody atezolizumab, it showed that in the mutated population, you had about a 70% pathologic complete response rate, so very impressive. You had something like a 70 to 80% RECIST response rate, whether you were BRAF mutated in 20 patients or BRAF wild type, who got cobimetinib plus atezolizumab alone. Of course, no BRAF mutation, so no reason to give a BRAF drug. But those patients did very well, very nice RECIST response rate, more than a 60% pathologic complete response rate if you were BRAF mutated, and about a 1/3 pathologic response rate if you were BRAF wild type. So those patients, of course, didn't do quite as well. But again, very nice data. And there were some correlative marker studies surprisingly showing that if you were PD-L1 positive or negative, no association with pathologic response if you were done by immunohistochemistry or soluble PD-L1 assay. So again, raising the bar in the neoadjuvant space, suggesting that if you're BRAF mutated, you could get BRAF/MEK plus atezolizumab, and you'd probably have a higher pathologic CR or near CR rate. And we'll see what the recurrence-free survival rates show when those data become available. This is Dr. Jeffrey Weber, and again, please do call in with comments, questions, and concerns. Thank you very much for your attention.